So I'm Chris Travis. I was invited to be host for this narrative medicine rounds. I'm really excited about that. Um, on behalf of the Division of Narrative Medicine at Columbia University Medical Center, I welcome those of you who are joining rounds for the first time, and welcome back to all returning attendees, old friends and new. Narrative medicine arose at Columbia in 2001, is now an international movement at the intersection of humanities, the arts, clinical practice, and healthcare justice. Narrative training ha- equips clinicians to humbly try to comprehend patients' experiences and perspectives in a way that delivers equitable and effective healthcare. This rigorous training and practice of narrative medicine helps all those interested in person-centered, respectful healthcare to deepen their self-awareness, clinical attunement, collaborative skills, and creative capacities. Our commitment to healthcare justice underlies our writing, teaching, research, advocacy, and delivery of care. The narrative medicine community assembles monthly at rounds to grow our knowledge, partnership, and commitment to a just and effective healthcare future. Before we introduce our speaker for tonight, I've been asked to mention a few basic Zoom ground rules to ensure that the program goes smoothly. Please keep your microphone muted to cut down on background noise during the program. If there are any disruptions or inappropriate comments in the chat, you may be removed from the event. During the talk, we ask people to keep the chat interactions to a minimum. As we get closer to the Q&A part of the event, we will invite you to submit questions through the chat for our speaker. But before then, we won't be monitoring questions, so please save your questions to type into the chat after we make the announcement. The event is being recorded. Everyone who's registered will get a link to it a day or two after the event, and you can share it as you wish. Captioning will be available during tonight's event. At the end, we'll have a link to the online bookstores to order books or find out more information about our speaker and the Department of Medical Humanities and Ethics and the program in narrative medicine. So Rachel Somerstein is a journalist and associate professor at SUNY New Paltz, and she's written this incredible book, Invisible Labor, about Cesarean Section. I'm an OBGYN by training, and I also trained in narrative medicine. And I was so excited to be invited to talk with her, and also to get the opportunity to read this book that talks about so many things I care so deeply about. Rachel has firsthand experience with this material, and she's taken a real deep dive into so many different aspects of C-section, from the history, the anatomy, the social implications, the economics, the stories of people like her, different from her, people that do birth work, people that do surgery, people that advocate for change, and frankly, people long dead. She has, quite a resume I won't get into too deeply, but she got her BA in English and History from Cornell. She got her MFA in Creative Writing from NYU, and her PhD in Mass Communications from Syracuse. She's written in the Washington Post, Wired, Guernica, and many other publications, and she lives in Hudson Valley with her husband and two children. Invisible Labor is her first book, and it combines memoir with assiduously researched journalism, and we're very lucky to have her with us tonight.
Thank you. Thank you so much. That was such a really warm welcome. I feel really honored to be here. I'm grateful to the Division of Narrative Medicine for inviting me, and really grateful to Dr. Travis for moderating this conversation. And I wanted to start by saying that this is really like a dream invitation for me, because so much of my book deals with narrative. In terms of the stories we tell about birth, and the stories we tell about motherhood, the stories we tell about obstetric history, C-sections. There's also, of course, my story of having had a traumatic birth, and how I integrated that into my identity and, moved forward as a person. But it's also really about the stories that we don't tell, the stories that are to the side, the ones that get overlooked, the ones that are not about the star of the show, but about the stage manager, as it were, to think about it as a metaphor. I'm really interested in those, and I have been for a long time. And I'm interested in them not only because of what their narratives are, but also because of what we can learn from why they're not in front of us, why we don't hear about them, that is super powerful, right? What forces are revealed to us when we consider these stories that are not the ones that are told. And also, I think when we look at the undertold stories, which we're going to do a little bit tonight, and which I try to do in the book, I think we then can also learn more about the stories that are most familiar to us, that are right in front of us. So I'm going to start sharing my screen and give me just a moment. Here we go. Start. And with this in mind about thinking of stories that are undertold, I wanted to start by inviting you to picture how birth looks in the public imagination. So by that I mean how it's shown on TV, how it's shown in movies, how it's shown on books, how it's shown in social media, the way people talk about it, right? What comes to mind for you when you think of the ways that birth is told, represented in the public imagination? And I'm willing to guess that the answer to this might look a little bit like this, which is this is a page from Diary of a Wimpy Kid. It's a series that my daughter is completely obsessed with. It's a graphic novel, which is highlighting obviously the doctor and this medicalized experience. And there's a lot that we could talk about just from this image, right? If this is emblematic of the public imagination. But in preparing for this talk, I did some of my own kind of looking around to see how birth is shown. And I looked at Getty Images, which is one of the largest purveyors of images in the world in terms of stock photography. So you'll see this in magazines and newspapers and other places. I looked for Google Images, and I Googled birth. What do we see? And there's a lot that we can talk about here in terms of what's left out and perhaps the cleanliness and, like it's pretty white, right? There's a lot of things we could talk about. But the thing that comes to my mind right away as we're having this conversation is that we just don't see C-sections. Like they're just not there, right? So I'll just go back if I can. Oops, I can't. So let me see if I can go back. You can see there's no C-sections here. It's as if they don't exist. And the reason why I think that's so interesting and deserves our attention is because of the numbers of them that we're doing, right? So just so we're all on the same page, this is data from 2022. C-sections are 1/3 of the births in the United States. They're the most common operation in our country and in the world. Yet they seem to not really count as birth, right? In terms of their lack of visibility. And to kind of get at that even further, I did this little Googling again before our talk, and I typed in, is C-section birth, seeing what questions Google would show me. And you'll see some of these are getting at what I'm talking about. Is C-section considered birth? Is C-section considered giving birth? And these questions, they don't come from nowhere, right? This is kind of, again, the public imagination regarding birth. And these are questions when I was reporting the book that mothers would ask of me, right? Did I even really give birth if I had a C-section? And of course, the answer is yes, but this is how people are feeling. So in that way, my book really seeks to change the narrative. I want to write cesareans into it, and I want to enlarge the picture when we talk about birth. And in doing that, that means I need to look directly at cesareans in order to see them in their fullness, in the ways that they save mothers' lives, they complicate mothers' lives, they shape mothers' lives. It means looking at what it really takes to recover from one. It means, considering their history, which we'll talk a little bit about tonight, which is very, very far from public view. It means looking at the reasons that Black women are disproportionately more likely to have them than white women. And it means exploring how our over-reliance on technology and the financialization of medicine come together to play a part in the numbers of them we're doing every year. And in looking at that, right, I then ask, what does then that reveal about us? What does all of that stuff that we don't look at, that we don't consider when we think about birth and when we think about C-sections, why does that matter? What does that have to say? So in order, though, to tell you about why I came to this topic, I have to tell you another story, which is a very personal story, which is my own birth. So when I first got pregnant when I was 33, I absolutely assumed that I would have a vaginal birth. And I made the mistake of believing that because I did these things as an individual to prepare, that would ensure that my birth looked a certain way. However, what I didn't understand at the time is that, of course, birth is unpredictable, but also there are so many forces that shape it that have nothing to do with me, right? From the culture of a hospital to the training of the people who are taking care of you, to the technology they're using, to the economics of the entire healthcare system. That has far more influence on my birth and on all people's births than whether a person does prenatal yoga 3 times a week, right? But we live in this society that is neoliberalist, right? It's very individualistic. And so those forces are not evident, not only, in terms of our ideology and how we're trained to think, but even in the ways that, we encounter pregnancy and birth. I talk about how my labor was a disaster in the book and how it went off the rails. And then the worst part happened when I got to the OR, which is that when the physician made the first cut and I told him I felt that, he said, "You'll feel pressure." And I said, "I felt that." And he continued operating. And what happened is that the anesthesia failed, but the operation continued. And I was expected to bear that pain. And I say this, and I have to tell you, it is still a shocking thing to say after 8 years. And I'm sure it is a shocking thing to hear, and it should be shocking. But when you drill down at why this happened, it happened because my physician didn't listen to me. He's not a bad person. He didn't want to cause that pain. I'm certain it caused tremendous moral distress to every single person in that operating room, but he didn't listen. And that is extremely common when it comes to women's experiences and women, people of color's experiences too in medicine. The issue is that in this case, the stakes of him not listening, they were immediate and they were extremely high. So when I began recovering from birth, I looked to literature for recognition. I needed to gain purchase because the birth threw my understanding of myself and my identity completely upside down. I needed a map to show me it was possible to get back to who I had been. I read everything I could about motherhood, but I didn't see any experiences like my own, or even many stories about C-sections in this narrative of birth. Even the very regular aspects of recovery, which for me was textbook, right? I had this disastrous section, but the recovery was pretty, textbook. They didn't accord to what I was experiencing in literature and the literature. So for instance, this is from one of the most popular pregnancy books, and you'll see that it says, instead of huffing, puffing, and pushing your baby into the world, you'll get to do lie back and let everybody else do the heavy lifting. That was sort of the attitude. It's the easy way out if you have a C-section, and, recovery is sort of like a parenthetical. Other representations seem to suggest that it was for women who are too posh to push. And it is so many things. C-sections are so many things, and they are not that. I'm a writer, but I could not write or even speak about what happened to me for several years. And at the beginning, I even asked my doula to tell my parents what had happened because I couldn't talk to them about it directly. Once I did start to work on it, writing the book was its own form of narrative medicine, not because it healed me, but because doing so enabled me to bring these untold stories of C-sections into the light. And that was really important, in fact, essential, because it gave me narrative agency. I took the reins back to tell the story of what happened to me and how also this operation has come to play such a big role in our culture and frankly around the world. So when people tell me that I'm brave for having written this book, which I know they mean with tremendous as a tremendous compliment because it was not easy, I also feel I had to write this story. I had to. How could I not write about it? And in fact, the very fact that I had the experience at all, it speaks to the power of narrative authority and my lack of it in the operating room. It's not new that women are unreliable narrators of our own bodies, and that's something that people with chronic health conditions struggle with, in particular, every day. But I'd not thought about myself as an unreliable narrator, and particularly when it came to something so embodied. There's one last thing that I'd like to say about including these underspoken, undertold narratives, and it's that in doing research for the book, I came across drawings and photographs of women's bodies who were the subjects of medical research during the development of C-sections in the 1800s in the United States for the most part. Often these women are rendered only as their reproductive parts, and I deliberately did not include any of the more detailed graphic representations, although there are many of them. These drawings were meant to read as objective representations of anatomy, but they had a crucial consequence, according to historian Nora Doyle, which is that they dissociated childbirth from the body of the mother. And in that way, these illustrations are emblematic of how childbirth has evolved to what it unfortunately resembles too often now, which is a mechanical and scientific and medical process that's basically about the expulsion of the fetus or the extraction of the fetus. And this is also informing, I would argue, our medical legal perspective regarding reproduction, whether a person wants to keep or terminate a pregnancy, which is that the uterus and the fetus are totally separate, that the relationship between the two is competitive, adversarial, it's me or you. That's at the core of the Dobbs decision, right? We're living that now. However, if you've been pregnant or you've been close to people who are pregnant or you've taken care of people who are pregnant, you will know that the relationship between the fetus and the mother, it's not adversarial, although it can feel that way sometimes. I eat that and then you do this, right? Or like you're rocking and rolling at 4 a.m. and I just want to sleep. It's much more complex and complicated and nuanced. And I offer these two ideas of how to think about this relationship, which is one coming from Marie Ash, who says that pregnancy is a state to which we can apply no number known to us. You're not one and you're not two, it's something else. And legal scholar Isabel Carpin proposed something similar, that a pregnant person is not one but not two. I would argue that, you know, new mothers in particular can attest that it's difficult to even identify when this process of separation to two people even happens, right? It's not just at the birth. The baby separating from its mother is this really slow unfold. The baby doesn't even know that you're not the same body, right? And the baby cries and you have a letdown. Like your body also doesn't know entirely that you're distinct, separate bodies. And I have a 4-year-old, and I think sometimes he's still working on this concept that we have two separate bodies, right? It's really distressing to him sometimes, I think.
My 4-year-old as well is confused about that fact.
Right? It takes a long time. But in researching this book, I didn't realize how accustomed I'd gotten to reading about these silenced, anonymous, and disembodied women who had been reduced to their malfunctioning or diseased reproductive organs until this one day I was reading a book, a textbook from 1911. I was by myself and I turned the page and I gasped because there was a photograph of a naked woman staring back at me. Before, I'd only encountered drawings because, again, this was really before photography evolved significantly to be used in textbooks. So at first I felt kind of excited when I saw these photographs because I was like, I'm finally going to get to see these women I've been reading about. But they were not posed to portray their humanity. They're here as types. And I should say these are photographs of women who were sterilized in the same operations in which they had cesareans, which is a really long, complicated history that I write about in the book. Um, you know, you can see, and if you're familiar with the history of photography, you can see that these people are posed as a way to categorize them and to show their so-called abnormalities, right? That was how photography was really used at the time. And I go to this phenomenal theorist, Donna Haraway, when I think about this, right, where she says that vision is always a question of the power to see. And what was amazing and weird for me in encountering these photographs was that my freedom to look at these women put me among the class of people for whom they functioned not as humans, but as scientific material. And that medicalized gaze narrowed what I could see about them, much as it limits what's visible about C-sections in the public culture. So I'm a professor, and when I teach and it comes time to write a paper, I always ask my students, so what's at stake, right? Why does it matter that you're analyzing what you're analyzing? And if I apply that to my own work, I can ask the same question. Who cares that C-sections are overlooked? Why does it matter that we do so many of them, more than is safe, probably, according to the editorial board of The Lancet, the WHO, and many other leading institutions? I have many reasons why this matters, but I'm going to focus just on two. The first is that cesareans shape the trajectory of mothers' reproductive lives. And what I have here is the cascade of interventions, which is often repeated as a warning to pregnant people. It's like a list of interventions to avoid during labor or even before that are said to lead to a C-section. So this can include, like you see here, getting even an IV, an epidural, Pitocin, an induction. And the concern that these interventions might lead to cesarean isn't necessarily wrong. And we could have a really rich discussion about, let's say, the relationship between induction and cesarean. My problem with this is that the narrative ends with a C-section. So according to this story of the cascade of interventions, that's the wrong ending. And then what do? Right? If you've succeeded in avoiding the cascade, good job. And if you didn't, too bad, the end. The problem with this frame is that overemphasizing the mode of birth stigmatizes cesareans and leaves mothers out. And what happens if we start the story in a different place? As I write in the book, C-sections are the beginning. They initiate a cascade of consequences that can last for the rest of your life. I didn't think that that was possible until I was living through it on my own. It's not part of the story we tell when we talk about surgical birth. But so many of the mothers I spoke to from vastly different communities, different ages, different ethnicities, even from different countries, said something similar to what these women said that's up here right now, that it just changes everything. For me, the C-section's trauma kept me from getting pregnant sooner than I probably would have if things had gone well. And it's not unusual to delay pregnancy if you've had a bad birth. But that's kind of not the only cascade of consequences potentially delaying if a C-section wasn't good. So I have here a couple of them, and there are many, but some things that a C-section can set in motion are this increased risk of secondary infertility, stillbirth, miscarriage. I should have here increased likelihood of placenta previa and placenta accreta, an increased risk of needing a hysterectomy later in your life. And most important, and I feel like this is my issue, I feel like an evangelist for this, is that you can now no longer just, if you get pregnant again, have the baby. You need to choose whether you're going to have a VBAC, which is a vaginal birth after cesarean, or a repeat C-section. So I just want to spend a bit of time on this because I think this is so vitally important, particularly given what's happening in our country right now regarding reproductive access. VBAC is completely legal. And to give you the view from 50,000 feet, and I'm sure that Dr. Travis could give more and better insights into this, a repeat C-section is slightly riskier for the mother, and a VBAC is slightly riskier for the baby. Both are relatively safe, okay? However, this right to access VBAC is really, in some ways, a symbolic one because an estimated 1 out of 5 hospitals will not permit people to try it. Those hospitals are clustered in states where it was hard to get an abortion, even when Roe was legal. However, geography will not save you. Probably 2 weeks ago, I was on the phone with a mother in LA who can't find a place where
Mhm.
she can be back. And this person has every advantage. She's white, she has private health insurance, she can travel, um, she has a supportive spouse, and she's still having a problem. And she lives in California, right? So this is a widespread issue. It's extremely difficult to find a provider who will attend a VBAC after 2 cesareans, and it's virtually impossible to find somebody who will attend one after 3 cesareans, with few exceptions. And I'm talking about people who are attending you in the hospital. This is an issue of reproductive justice because the same person who wants a VBAC is the person who needs an abortion, just at a different point in her life. And what we're not doing is making the connection, I think, when we talk about reproductive justice, that VBAC and C-section are part of that too. Access to midwifery is part of that too. There's a lot of support, although of course we need more, for mothers or people who need to travel to access an abortion. We don't have that for VBAC. At the same time, I want to say that having a C-section, in terms of initiating this cascade of consequences, they're not all bad. And I will say that personally, I would not have written this book if it hadn't been for my cesarean. So the shift in your trajectory isn't necessarily or always negative, but it is significant. So what I can offer you is that surgical birth, I think about it like you're falling through a trap door. It shapes how you come to motherhood, how many children you ultimately will mother, and what options are open or closed to you in the future. But none of that is evident from the way that we overlook cesareans. The second reason why we mustn't overlook them is that the number of medically unnecessary ones we're doing perpetuates racist care. And it has serious consequences for women of color and Black women in particular. So I just want to take a minute to share some data with you about the degree to which surgical birth has increased for everybody, um, before we zoom into looking at the disproportionate rates for Black women. So in 1970, the rate was 5.5%, and in 2023, it's about 32%. This operation has increased so dramatically over the course of basically 50 years. I mean, for nothing else, we need to attend to why and what are the downstream effects going to be. To also make clear, the reason why the rate isn't even going up even any higher is that actually VBAC is starting to increase. The number of primary cesareans, meaning like the first time you're having one, has been increasing despite how hard so many people are working to bring this number down. So what's going on with that? In terms of the disproportionate impact, you can see here the gap between Black women and white women and Black women and all of these other ethnic groups is higher. And even initiatives that have worked to bring down the number of cesareans safely and that have done so, like the California Quality Maternal Care Initiative, the gap persisted, right? So they were able to bring down the numbers of C-sections for people in the hospitals that participated across the state, but the gap was still there between Black women and these other ethnic groups. So if we want to zero, and I should say, actually, let me just add one other thing. Sorry. There's also this recent data that's come out. I'm sure some people have seen in the New York Times. There was this piece covering a recent study of 1 million births in New Jersey that showed that even a person seeing the same doctor in the same hospital, a Black woman was 20% more likely to have her baby by C-section than a white woman. And there are so many reasons for this, and they come down to racism, right, at the interpersonal and systemic and structural levels. And I'll give one example of what I mean by that. So there are not enough midwives in the United States to meet demand. And actually, earlier today, I was talking to a class of future midwives, and it takes a long time to train a midwife, just like it takes a long time to train a physician. This is coming from Mimi Niles and Lori Zeffrin's study, and you can see the the gap between people who had a midwife at their birth versus would want or would consider one for a future birth. And the gap is there for all of these groups, and it's largest for Black women, which is a social determinant of health. What does this have to do with C-sections? Well, if you have a midwife and it's your first time, it's your first birth and you're low risk, you're less likely to have a C-section. And that's true here and worldwide. So if we're talking about we want to bring down this number of C-sections, one way to do it is to make sure you don't have that first one, because the greatest thing that's going to predict that you have another one is having had one in the first place. This is totally not, I think, in our line of vision when we talk about birth or when we talk about cesareans. Okay, so I started this talk by discussing my interest in stories that are undertold and what they can reveal in addition to their narratives. And when I think about the ways cesareans aren't fully looked at and the ways that we avoid them, I think about how that's symptomatic and emblematic of the degrees to which we do an extremely bad job of recognizing and addressing women's pain. I have a couple of examples here. This was a piece recently in the Times. Only fewer than 5% of physicians offer a local anesthetic when they're inserting IUDs, which, people I know who've had them have said it's more painful than even labor. We have ample evidence that women's pain is undertreated for a variety of diseases, from cancer to AIDS to abdominal surgery, other operations. It begins in childhood, actually. Girls are given or offered less pain medicine following surgery than boys are. And another example of this is how long it takes to be diagnosed if you have endometriosis. Again, it's hard to diagnose, but there's also embedded in that this dismissing women's pain. I think that if we talk about also what's happening in the country in terms of Dobbs, that's another aspect of this denial of women's pain, and also, of course, denial of women's full authority. But we have to think about, again, the way that we are overlooking C-sections in their entirety through this overall lens of denying or addressing or recognizing women's pain. Looking directly at cesareans and at the full set of risks that they pose to mothers also sets into clarity the full risks that the operation poses to a mother's life. And actually, I should go back to this slide. Again, that's what we're doing since the Dobbs decision, right? We undervalue mothers' lives. And this ideology plays a role also in the criminalization of pregnancy, which is this slide. There's a new report out from Pregnancy Justice, which talks about how since the Dobbs decision, there were more charges brought against pregnant people than ever before since the organization began to count. And most of these charges that were brought against pregnant people had to do with drugs. The twist here that's so sad is that by criminalizing pregnant mothers, we make it less likely that they'll seek help for drug dependency. And the consequences of that are very serious because the majority of deaths related to pregnancy happen postpartum and are due to overdose and suicide. And that's, I would argue, another aspect of the story of birth in terms of the maternal health emergency that's undertold. Finally, looking directly at C-section history demonstrates the degree to which we have not reckoned with slavery's impact on our culture, the ways that its ideology of white supremacy grew up alongside so many aspects of our culture, our society. Helena Grant, who's one of the midwives I interviewed for the book, told me that the US's brutal lack of postpartum support stems from our treatment of enslaved mothers. As a Black woman, I feel it comes from seeing the tenacity of women who were brought here enslaved and forced to do plantation work and breed, she says, have a baby and get right back to work. In time, that legacy became harmful for all American women, promoting capitalism at the expense of human life. And I have here another quote from this woman I interviewed in the UK who I asked about the support for people in the US after they have a baby. And she gasped and she said, "That's barbaric. How do people even have children?" Which is what the response should be, but we don't think like that because we live here and we're used to it. One of the most undertold aspects of C-sections is their history. And when I was reporting this book, I was often asked if it's true that C-section started with Julius Caesar, if he was really the first C-section baby. And the story is likely apocryphal because at the time, as far as we know, cesareans were used on women who'd already died during pregnancy to give their babies a chance to survive, and when the Catholic Church was involved, to be baptized. But what's really interesting to me about this fictional story is how widely known it is, and that it overshadows the real history, which is that cesareans were developed on enslaved and othered women. And it's really remarkable how thoroughly and consistently we look away from that. Deirdre Cooper Owens writes about this in her book, Medical Bondage, but effectively, a colonial Virginia law that passed in 1662 held that an enslaved woman's children would have the same status as their mother. Black women could then build capital for enslavers through birth, which was even more important after the US banned the transatlantic slave trade in 1808. And that's why physicians and slaveholders were more likely to gamble on an enslaved woman's stuck baby and do a C-section because they had a chance of saving both the baby and mother and adding to their stable of enslaved people. They were willing to take this risk because enslaved people's lives were expendable and because an enslaved woman's value was linked specifically to her capacity to bear children and enlarge her master's wealth. One of the pioneers of the surgery, Francois Marie Prevost, who was born in France, moved to Haiti, and then after the revolution to Louisiana, was a slaveholder who owned 40 people, including 10 children at the time of his death. And I think what's important to attend to in this history is that it shows that these disparate rates of C-sections on Black women, they're not new. It's been this way since the operation's genesis. I wanted to close by inviting you to imagine how we can make birth better for everyone, for mothers and families and clinicians. And that might be something that you imagine with an image, which I don't think we have that image yet, or maybe I haven't seen it. Maybe it's something from your birth or from a birth you've attended or a birth that you heard about or a birth that took place in the past in your family. I'll leave you with this image, though, which I think gets at what surgical birth is and what it can be, which is both a moment of joining and a moment of separation, an ending of a number, not one and not two. And thank you. And I'll stop sharing my screen.
Thank you, Rachel. Where do we even begin? I, you know, as an OB myself, C-section is one of the first things you learn. And I remember learning indications from C-section for C-section because I was so eager to do them and to learn how to do this important procedure. And that was what the first half of my residency training was about. And I think the more difficult part came in the second half, where it was really learning how to prevent them. Because I mean, they can be life-saving, but the number of times we run somebody to the back and it's all chaos and trauma, and OBs will say, "Oh, the baby's going to come out screaming," which is our way of saying the baby's actually going to be totally fine, but we feel compelled by the evidence in front of us that we have to intervene. So it's a very complicated problem.
Yeah, and I have thought, I've taken some walks and had some long conversations with different providers, and I've thought, if I were in that room looking at that electronic fetal monitor that gave me some pause or that seemed not to be reassuring, it would be difficult, particularly if I were new, to mentally override that. And as a non-clinician, what I can relate that to is like, and this is very low stakes comparison, but when you use Google Maps and it's like takes you on this cockamamie route and you're like, well, I think there's probably a better route, but it says I should do this and it'll save me 5 minutes. So, okay, computer. I mean, that's the society we live in. It's extremely difficult. And when you're dealing with something that really is life and death, plus potential of litigation, Plus, you actually can't be 100% sure, and also potential of lifetime of harm for a harmed baby. I'm sure it's extremely difficult.
Mhm. It's there's no neat answer to, I think, how to manage those situations except, I don't know, do it sincerely. Like I'm always much more comfortable with my management of um, those complicated situations when they are abstract or when they have already happened and not when they're in the middle of happening. So I'm always thinking to myself, oh no, this is the one. This is the one where you're gonna screw it up, Travis. Um, I do want to ask you, because I think that you do such a great job not only talking about and showing us the way that historically bodies have been regarded and how different bodies have been treated differently. What do you what do you feel like you you and your body have learned from C-section and from writing this book and talking to these other people and all, like what's sort of like what do you kind of take away from it?
Well, I can answer that question like personally and systemically. So I think on the personal level, since my C-section, I no longer have the option to ignore my body. And in some ways, that's extremely annoying. And in other ways, it is a gift. I no longer can just hit override because of the ways that the operation caused PTSD, frankly. And that can be very distracting and interrupting, even though I've really dealt with it through therapy in a way to bring it down, to shrink its footprint. But I also probably spent a lot of time, even though I used to think of myself as someone who was in my body, I'm a yoga person. I was like treated myself, and I think this happens also sometimes to people who pursue higher education, and also just people, I don't know, of a certain inclination. I treated myself like I was this like brain on a stick, like my body carted my brain around, and that's not good either. So it gave me that, and the process of writing the book gave me that. And I think that the other thing it gave me is systemically just to think that unfortunately, when I think there's a lot of ire toward clinicians, and there certainly are clinicians who do things that are not good. And what's left out of that picture, I think, is what is the hardest and the most critical to address, which is things like social determinants of health, right? Which is things like financialization of medicine. I mean, that's something that's so serious and that is affecting every single specialty, certainly not just midwifery obstetrics. Um, and those are when you're thinking about how stuff gets covered in the news, which is what I do in like my other job. Those are abstract, right? It's harder to assign blame than to be like, this bad doctor did X, and I think, I mean, that's even like the ways like the maternal health emergency is covered, right? The stories that get attention are these horrible tragedies where people didn't listen, and those are real and they happen and they're horrible. And the vast majority, as I'd mentioned, are actually happening after people are pregnant and have to do with mental health issues, right? That are not attended to. We don't have systems to take care of people postpartum. So again, what gets covered is like I can assign blame as opposed to like the way we've set up our society is responsible for a lot of harm and a lot of damage. And we can change that. We built our society, right? We have that power.
It, the part of what's coming up in the chat right now is about obstetric violence, and I the number of times I've had a patient, heard a patient talk about horrible things that have happened to them, or you talk to them and you can see the fear. I remember I had a patient when I was a resident who, by all indications, was going to have a vaginal delivery. Everything was going totally normally. She just happened to be dilating, and so we got the table set up to have a vaginal delivery and just have the towels and the instruments and stuff. And her doula immediately became afraid. Are you guys going to do a C-section? And I think that it speaks to the way that we have, like you said, completely occluded the nuances of birth from people in a tons of ways because it's not happening at homes, generally
Right.
speaking. So people, people aren't super familiar with it. What do you think sort of gets at what we can do about the violence piece of it? Because that I think like there's certainly violence to a under anesthetized C-section, but there's also violence to doing a cervical check without asking permission or just barging in, or there's many layers to it. So what are your thoughts on that part of this problem?
I mean, again, I get to have the privilege of talking about this as not a clinician, right? I'm not in the seat, but I think that it seems to me that all clinicians should practice trauma-informed care for
Mm-hmm.
every patient because you may not know what they're bringing into the room. And I'll give myself as an example. When I go to the doctor, I look, I'm very, very, very nervous. I get really scared. I look completely calm. I have a very strong container. That's how I
Mm-hmm.
was trained. Maybe it's even biological. I would argue my parents are the same way. And um, as a result, and I'm there, I have my private insurance, I don't have like chronic health issues. A provider who's not practicing trauma-informed care, and that doesn't have to even necessarily be somebody who's a midwife or an obstetrician. It could be, like the ophthalmologist, right? It
Mm-hmm.
could be the dentist, might have no idea what's going on for me in my body. And I'm not inclined to tell them. I don't need to walk around being like, let me tell you about this horrible experience I had when I was giving birth, right? Because then that also creates kind of violence for the person. Like, God, how many times do I have to tell this story to people? My goodness, right? And in these like very vulnerable spaces. So I'd say everybody should be practicing trauma-informed care, period. And I hope that the legacy of Me Too could start to shape practice in terms of you need to actually ask consent before you touch somebody. And
Mm-hmm.
not in a way that's like, I'm just going to go give you a surgical check if that's okay while you like lean over and do it. I think one of the problems of Me Too, unfortunately, is it's made all touch seem sort of up for inquiry or like suspect, I guess is a better way, right? And again, like Me Too did a lot that's really valuable, but we also are living in the society where we don't have enough good touch. And I think especially in maternal care, we don't have enough
Yeah.
good touch, So I would say even something like when a person goes into the operating room, and this came up in this conversation earlier today, a laboring mother, if that person has a supportive provider, gets a lot of good touch, holding, right? You get into the OR and suddenly you're a patient. Nobody's touching
Mm-hmm.
you in a holding grounding way. And I know that's something that a support person can do, an anesthesiologist can do that, and some anesthesiologists do that in this really powerful way. So I think remembering in terms of the violence piece, this is a person, it's not just a patient with a whole history who's scared and needs reassurance.
Yeah.
Hope that's a helpful answer.
Yeah, I mean, I feel like part of what you're getting at is the violence becomes more possible with the dehumanization of transform or putting people in the sick role, right? You put the drapes up, you have somebody to take care of all that noise she's making, and you do your job. And that is a recipe for violence. But I don't remember if it was you talking about your C-section or someone else's, but the anesthesiologist holding the hand.
Mhm.
And, as the surgeon, I don't see that part. But the idea to me of the anesthesiologist holding the hand of the woman under the drape is so lovely.
Oh, it's so
It
beautiful.
it
Yeah.
it just and so easy. And there's so many little things like that can be done to make this sort of thing more human. The last time I went into an operating room, I was surprised because the dad was already in there because I was at a different hospital, and the way that they did it, dad got there before the surgeon did.
Mhm.
There wasn't this. We'll get everything all set up and then we'll call dad in, and that you know you haven't deprived a woman of her support person the whole time until the very end. Once we don't have any more preparing to do. Um, and like these are avenues towards less violence because I think they're avenues toward humanization.
Yeah, and I
Um,
think that's sort of what happens in to the extent that I understand it, pediatrics, right? Like we take these experiences that could be really scary and hard and we try to make them a little nicer because they're kids. So you go to the pediatric ER and there's like this beautiful mural and like when the kid is having a surgery, both the parents are in the room until the person goes under. Like of course there are issues with sterility and space in an OR and all of this, but why everybody could use, a medical experience to be a little bit nicer, not just because they're under 12, you know? And the other thing that what you were saying that made me think about is, the dehumanization of the patient. It's what can we do for the providers too, right? To
mhm.
support providers to be able to walk this line of doing the job and not letting the job eat them alive, which I'm sure you have to split yourself somehow, but also by recognizing your patient's humanity.
Well, I think that the Cartesian presumption that you have to split yourself in order to do the job, I think starts us off on the wrong foot.
Mhm.
So one of my best attendings, she would always say, when you're really not sure what to do, you need to ask the patient. When you're really stuck, you need to say to the patient, I'm stuck. I'm not really sure what to do. We could do this, and here are the risks and benefits, or we could do this. Here are the risks and benefits. And talk to that woman and let her understand what's going on and see you wrestling with it. And then she can make a decision, or you can make a decision together. And then you're not just meeting her as the authoritative doctor, surgeon, wizard. You're saying, you're person to person. I'm stuck. Well, I'm here laboring with you in a way.
Mhm.
What what can we do? What are you comfortable with? And that I think has really shaped the way I try to counsel patients and keep keep my sort of like scientific expertise and experience and my human vulnerability completely stuck together and right there with the patient in the situation. You sort of have to be willing to feel that vulnerability. Because what if she says, "Wait, but you're the doctor. I didn't know you were so dumb. Why are you worried about this? What a wimp." You have to be willing to uh, get that reaction, and I've yet to get that reaction.
Well, it takes
Patience.
humility. What you're talking about takes tremendous humility, but I think it also speaks to this need, and I think it speaks to this need for more education prenatally, which not to again bounce us back onto the providers because clinicians have so much to handle during prenatal care, and the appointments are simply not long enough. But the opportunity to explore these questions, if we get to this, should we do this or this before it's acute? I think that that is really, really important. And to give an example, one mother I talked to, she was really anxious going into her C-section. She'd had a high, she's developing preeclampsia, went to the hospital. And they were like, we counsel you really to have the baby now by cesarean. She asked the anesthesiologist, what can I have for my anxiety? He said, you could have XYZ, but it may cause memory loss. And, it's good that he told her that. That was really important.
Mhm.
And the moment that she was learning about that, the risk and the benefit shouldn't have been as she's going into the OR, which was not the anesthesiologist's fault, right? That's the structure of prenatal care, I
Yeah.
think. So again, like I hear what you're saying, how amazing to have that exchange in the moment, and how can we integrate that into the culture of pregnancy,
Mhm.
um, beginning from when you first go in.
I think a lot of what we're talking about really underscores why so many people avoid care. And I
Yeah.
mean, like there, it wouldn't surprise me if somebody read your book and said, "See, this is why I would never go to a doctor." Right? What what are your thoughts about that? Because I totally get it. It's like it makes all the sense in the world, but I think it is a good place to wrap up because we've only got a couple of minutes. What are your thoughts about that?
So, I hear this question. I've heard this question a few times in terms of like, well, you don't want to scare people. You don't want to scare people out of going to the doctor.
Mm-hmm.
And I 100% agree. And the last thing I would hope to happen was that someone would read my book and be like, I'm never going to trust a doctor again. Because actually, in the outcomes of the book, there are clinicians who took such beautiful care of me and enabled me to have um, a VBAC, for my son's birth, which more important than it being a VBAC, it was a beautiful birth. I was respected. I felt safe, even though it took place during the pandemic. And that was because I was with people who recognized me, my humanity, from the nurses to the midwife to the OB. So I would say the line of, what do you do? How do you inform people without scaring them? I mean, the thing that I say is like, the last thing I want to think about is my death, right? Not my favorite topic. However, I still have life insurance and I have a will. And that's because that's what I need to do to be responsible. Was it fun preparing a will? No. Did I cry? Yes. Was it fun shopping for life insurance and going through the whole thing? No. I now no longer have to think about it. And should this come to pass, it won't be my children's problem to figure it out or my husband's problem to figure out, well, what did Rachel want? So I would argue that we need to share this information in a way that's like, this might not be a fun conversation to have. However, let's talk about this now so that in the unlikely scenario, bum, 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 you've had a chance to reflect and think about it. And I think I would think that that would increase trust in clinicians, right? Because it's not a surprise, right? Then you're not like, why didn't you tell me? And
Yeah.
that was one of the number one things that mom said to me was, nobody told me that. And I think that that is what erodes trust.
Yeah.
Nobody told me. Nobody told me.
I remember as a first year medical student, one of my attendings saying, "This isn't peekaboo. We're not here are the answers to the exam. You need to learn it so you can, you can be a good doctor." And I think that sometimes we play peekaboo. Oh, we don't want to scare you. We don't let's not talk about something that on its face there's a 30% chance will happen to you.
Absolutely. And that's so patronizing, right? I mean, and again, there's like a way of delivering this information without it being like, I now need to, scare the crap out of this person, but to be like, let's talk about it. And we do this, frankly, with like preeclampsia, gestational diabetes, right? That's part of prenatal education. Here are things that might happen. You should be aware of them. Here are the signs, right? It's far scarier to encounter some kind of I don't know, bad experience or obstacle or outcome and have no preparation whatsoever and be like, am I the only person this has ever happened to? What am I going to do?
Yeah.
And I say that from experience. I had this terrible C-section in terms of the anesthesia. Thought it was the only person in the world that ever happened to. And guess what? I'm not. It actually does happen, not necessarily to the degree that I experienced, but it does happen potentially in 10% of births. So putting that on the map is something that people can then, you know to communicate about and clinicians can be more aware of, and there can be, here's how we're going to address this should it happen. Again, it's far scarier if it does happen. We haven't had these conversations in advance.
Yeah. Yeah. And I mean, I think a lot of what you describe in the book is putting the patient at the center of what's going on instead of somehow moving her to the periphery and then ideally going there and being there with her.
Right.
And I think it's a good place for us to end. I mean, we could do this all night, I feel like.
Mm-hmm.
So thank you everyone for coming tonight, and for all of your questions. I tried to sort of synthesize them as best I could. A recording of tonight's event will be shared later this week via email to registrants. We hope to see you all next month on November 6th. We'll be welcoming Garth Greenwell, award-winning author of What Belongs to You and Cleanness, who'll be speaking about his most recent novel, Small Rain. See you then. Thank you so much.
Thank you.
Thanks, Rachel.
Thank you.